male in his 70s presents with acute breathlessness. What are the findings? Let's go through the case. We can see this patient is unwell. We have an AP erect film done in resus, and there is a defibrillator pad on the right. When we look at the right lower zone, we can see widespread faint opacity. Looking closer, we can see air bronchograms, meaning this represents consolidation. Now remember, consolidation is not always infective and simply means something is causing extrusion of gas from the air spaces. There are subtle peripheral septal lines, also known as curly B lines, which suggest the findings could be due to pulmonary edema. In this case, the inflammatory markers were not raised, and there were clinical signs of pulmonary edema, which helps us make the call. There is another finding, however. If we look through the defibrillation pad, we can just about make out an opacity, which was called on the initial film. The patient was diuresed, and a follow-up PA film firstly shows an improvement in the faint bilateral consolidation and septal lines, but also confirms the right upper zone opacity. If we look closer, we can see some associated distortion of the pleura. Given that this patient is a smoker, we need to consider a primary lung cancer. A CT scan shows a right upper lobe lesion with air bronchograms and associated distortion of the visceral pleura, suspicious for a primary lung adenocarcinoma. In cases of suspected lung cancer which could undergo radical treatment, a PET-CT is usually performed. This shows moderate FDG avidity within the lesion and no uptake anywhere else. A CT-guided biopsy proved a primary lung adenocarcinoma, and the lesion was successfully resected before the presence of any nodal or metastatic spread. The lesson here is to be extra vigilant when you have external objects on X-ray, as this could save your patient's life.